Yes, we are live now.
Good evening, everyone. Today we are conducting our monthly CME of talks. This CME is special in the sense that it is done in association with our Kerala Federation of ONG, and it has been done on this KFOG President's theme of turning vision into reality. I request Dr. Nishi Roshni, President, Thrissur ONG Society, to give the welcome address.
Thank you, Rashmi. Respected senior members of the profession, my dear friends, and all the PG students, a warm welcome to all of you to this webinar that is conducted by Talks in association with KFOG President Team, Turning Vision to Reality, organized by Jain. As you all know, what is our vision? Our vision is reducing the maternal mortality. Our aim was to reduce it to 30 by 2020 and 20 by 2030. And nearly our maternal mortality now is 29, and we have to achieve a mortality rate of nearly 20 by 2030. We know our President Ambuja Madam is nearing her tenure of 2 years. She was a vibrant person who was leading KFOG very efficiently with the support of Dr. Venu Gopal, the secretary. And Madam is also the confidential review of maternal death state coordinator, and she was also very working very hard in conducting all the CRM, DMD and MNSR meeting, and also in all the organizing all the IMOCAL, ORRT and various programs to reduce the maternal mortality. First, let me welcome Ambuja Madam itself. Madam is the HOD OBG Government Medical College Thrissur and Chairperson CRRI. Warm welcome, Madam, to this program. Next, let me welcome Dr. Venu Gopal, the Secretary General. He is also working as consultant ARMC Thrissur. A warm welcome, Dr. Venu Gopal, to this meeting. Next, let me welcome Dr. Premila Menon. She is the Secretary of KFOG, currently working as Additional Professor OBG Amala Medical College. A warm welcome, Dr. Premila, to this program. Next, let me welcome Dr. Rashmi Sia. She's a scientific coordinator of talks, and Madam is working as additional professor OBG Government Medical College Thrissur. Welcome Dr. Rashmi to this program. Next, let me welcome Dr. Serena Galvas. Madam is the professor and HOD Jubilee Mission Medical College Thrissur, and Madam is conducting the panel discussion today, focusing on high-risk pregnancy, which is very important in reducing the maternal mortality as well as reducing the near-miss cases. A warm welcome, Madam, to this program. Next, let me welcome Dr. Meera Ravindran. She is a consultant obstetrician gynecologist, Daya Hospital, and Madam was a colleague of ours when she was working at Thrissur Government Medical College. A warm welcome, Madam, to this program. Next, let me welcome Dr. Reena Ravindran, Additional Professor OBG, Government Medical College, Thrissur, my own colleague. A warm welcome, Dr. Reena, to this program. Next, let me welcome Dr. Bindu Menon, Professor of OBG, Jubilee Mission Medical College, Thrissur, and a warm welcome, Dr. Bindu, to this program. Next, let me welcome Dr. Jita S, Assistant Professor OBG, Amala Medical College. A warm welcome, Dr. Jita, to this program. Next, let me welcome Dr. Shamala M, Consultant, Palana Hospital, Palakkad. A warm welcome, Dr. Shamala, to this program. And I welcome all of you to this program. Before I conclude, I'm happy to congratulate Dr. Merin and Kenta from Jubilee Mission Medical College, who has become the first in the first round of UFOXY quiz held today. Congratulations. Next, let me welcome all of you to this very important webinar. Let me conclude. Thank you. And I invite Rashmi to continue this program.
Thank you, Madam. Now I invite Dr. Premila Menon, Secretary of Talks, to say a few words about this society matter and introduce and invite for felicitation the President and Secretary for Talks.
Okay. Thank you, Rashmi Madam. Good evening to all. Good evening, Nishi Madam, Ambuja Madam, Venu Sir, and Serena Madam, and all the panelists, all the viewers, Talksians, my friends and students. So before I say the society matters, let me take this opportunity to congratulate our Ambuja Madam for successfully going to complete her tenure of 2 years. I think KFOG's name has never before come up this much. Under her leadership and Banusar's leadership, KFOG has reached unparalleled heights. And I think now people actually wait for those KFOG updates. All over India, people want to listen to those KFOG updates. So congratulations, madam, for making KFOG actually famous. And regarding society matters, I think we had a meeting previously. I had almost told all the society matters in that meeting. And I know this week has been really hectic for all of you. On Monday, we had our academic and research committee activity and a very useful talk by Shaji sir and an interesting and enthusiastic talk by Geeta madam. And then yesterday we had our Pailisas talk. And today, as madam said, we had conducted the preliminary round for selecting the PGs who are going to represent talks at UA-Foxy Visakhapatnam. And first of all, let me congratulate the quiz masters who conducted the quiz successfully, Dr. Deepak AV and Dr. Pradesh. Thank you, Deepak and Pradesh, for successfully conducting it. And Dr. Merin and Dr. Henna from Jubilee has come out as the winners. Congratulations to the winners and congratulations to all the teams who participated. And today we are having this CME, and one more CME is on the way this week itself. Actually on Saturday, along with KFOG Reproductive Medicine Committee, you have got an update on PCOS from evening 5 o'clock onwards. I'll be putting the link and the brochure soon after this meeting. I didn't want to confuse everyone with all the brochures. That's why I didn't put it till now. After this meeting, I will put the brochure. And as all of you know, Women's Day is coming. So Foxy has requested all its societies to do some amount of cervical cancer activities. So I request all my colleagues to do some, at least some bit of cervical cancer activities, classes or some camps or something in their hospital in small scale. Even though at this time we can't do anything big, but in a small scale, whatever you can do in your hospital, I request all of you to do. Okay, thank you. And may I request now Ambuja Madam to felicitate this meeting.
Respected President Talks, Dr. Nishi Roshni, Secretary, Dr. Pramila, Scientific Committee Coordinator, Dr. Reshmi, KFOG Secretary, Dr. Venu, senior members, and my dear friends, a very good evening to all of you. And first of all, I should thank Dr. Nishi and Pramila for those nice words about me. The theme of my tenure, translating vision into reality, was actually meant to actually achieve the goal of MMR 30 by 2020. And we have always been telling about zero tolerance to maternal deaths. And during 2020, we had actually planned so many programs, but because of the COVID, we could not do anything except using the online platform to increase our knowledge. And I should say that whatever I could do for KFOG was just because of my vibrant secretary, Dr. Venugopal. And regarding the theme, I am very happy that we have achieved the goal of MMR of 29 during 2020. Yesterday, our state coordinator, Paili sir, officially declared to achieve this goal to the whole world in the Kerala Health webinar. It was a great moment for all of us, and we should be proud about it. Behind this success story, we have good leaders, we have committed obstetricians, we have committed non-obstetricians, and a lot of nursing staff in all the delivery points. And this has to be sustained by our sincere work, which should continue, and we should aim at 20 by 2030. Today, we have a program of panel on high-risk case scenarios in obstetrics, and I congratulate and appreciate the efforts taken by Dr. Reshmi and Dr. Pramila to arrange this program. And the moderator is none other than Dr. Serena Gilbas. She is the president-elect of 2022, and we know how she conducts a panel. And we have a variety of panel members also who are all new faces, actually all practicing gynecologists. And I'm sure this is going to be a very useful session. And I wish this evening webinar wonderful learning experience to everyone who has joined. Thank you very much.
Thank you, Madam. May I now request Venugopal Sir, Secretary KFOG, to say a few words.
Respected Ambuja Madam, President KFOG, Nishi Madam, President of Talks, seniors in the audience, and my dear friends. Thank you for having me to deliver the felicitation. It is indeed a proud moment for us that Ambuja Madam is President of KFOG, and she had such a wonderful theme for the year, translating vision into reality, which has become a success. At the center of this particular success is the effort put in by Talks. And I think in Kerala itself, the Thrissur ONG Society is the center of all the activities, and the the dynamism and enthusiasm of our members has contributed a lot to this particular success. I congratulate my own office bearers of Thrissur ONG Society for this. And then it is a great thing that Talks is holding a meeting which recognizes the contribution and the theme that turning vision into reality. I extend my best wishes to this program, also to Sarina Madam, who will conduct today's panel. Madam is fit because she is. I also want to congratulate Sarina Madam also, because she has also been elected to become President of KFOG, and I extend my best wishes to each one of the panelists and participants. And I want to say only Jai Talks and Jai KFOG also. Thank you very much.
Thank you, Venu sir. So we'll move on to the first introductory session on Genitry. It's a portable bedless monitor, fetal monitor, where many people have been asking what about Genitry once this brochure has been out. So Mr. Arun Agarwal of Genitry will enlighten us on the newer method of fetal monitoring.
Thank you. I would specifically like to thank Kerala Society and the Thrissur Society specifically, and special thanks to Dr. Sarina, because I know her since last 4-5 years, where we started this journey of like what sort of a problem we are facing in the labor ward during the labor phase, and that is where I founded Genitry in 2016 to solve some of the problems during the intrapartum monitoring. So Genitry, we are based in Bangalore, working with a vision to see a world where no mother or baby die during pregnancy, delivery, and post-delivery. And we want to innovate products. We want to bring it solutions which can literally help staff nurses, midwife, obstetrician, gynecologist in their overall process. So I would like to talk about Genitry by sharing my screen. So Genitry at the moment focusing on improving the labor monitoring experience, improving, developing the product which is affordable, which is easy to use, which is portable, and can be used by the staff nurse and midwife during the labor phase, and gives intelligent alerts. So I have already discussed about our vision, and this is what motivates us, because the maternal mortality and infant mortality rate is too high. And we also believe that technology can also play an important role in reducing these MMR and IMR number. So during the labor phase, what we have figured out, so fetal heart rate, contraction, maternal heart rate, these are important parameters to monitor the status of both mother and fetus. But what we have now, we have the existing fetal monitoring devices which works on the Doppler and Topo technology. Again, required, has to be placed on a very specific position on the abdomen with the belt. Again, required a skilled healthcare worker to operate these devices. It just print the output in a graphical format. It does not even transmit the data. On the another front, WHO Partograph is something which is a decision-making tool, but now it's just become a paper record tool in most of the cases. and it gets filled after delivery. I think everybody accept that. We figured out what are the issues is there. So what exactly we are working on? So this is the product which we have worked on. So this is a very portable electrical signal based fetal monitoring device. This works on the fetal ECG and uterine EMG, but ultimately it gives you the fetal heart rate contraction and maternal heart rate. It has this beltless monitoring. It's just an electrode based. No need for the placement change. It can give you both numeric and graphical format. It communicates wirelessly with a mobile application. So you can look at the data anywhere you are. So if you're sitting in OPD or sitting at your home or traveling, you can look at the data in your phone. It gives the audio, visual alert and alarm system. And you can also have the centralized monitoring at your nursing station, looking at the data for multiple patients simultaneously. What we have specifically done is we have brought the modularity into our product. So each and every hospital setting can be catered, whether it is a primary, secondary, or tertiary, both in public and private. Every labor ward acts in a different way in terms of manpower, in terms of end-to-end operation. So how it is better? Number one, it is a beltless experience. So it works on the fetal ECG and uterine EMG principle. So it doesn't work on the Doppler and Toko principle. So there's no need for the belt and all. It's just an electrode which gets placed on the abdomen. Single time placement. It can differentiate between the fetal heart rate and maternal heart rate because it works on the fetal ECG and maternal ECG principle. For contraction, it works on the uterine EMG principle. So this is the another modularity where you can say a lot of hospital really wants to see the data on the bigger setup. So we have this sort of a device which comes with the station with the 10-inch tablet. So this device wirelessly communicates with this 10-inch tablet where our software runs. And simultaneously, 3 devices can also communicate with one tablet. Now we have designed in such a way, it can be put it on the trolley, it can be put it on the wall, or it can be put it on your nursing station. So if you look at this Pro Plus, so when we were talking to a lot of obstetricians, we figured out they're not very comfortable at the moment looking at the data on just their phone and tablet. So they want to see the data on the thermal printer paper. So we have also considered that as a modularity in the product. So if you want, the thermal printer can be added and the fetal heart rate and contraction graph can be printed on the thermal paper. And the 3 devices, so that means if you have 3 labors simultaneously, 3 devices can simultaneously communicate with this one tablet. So you can monitor 3 at a very affordable manner. Now, the application which this device interacts, it has a lot of other features just apart from just showing the fetal heart rate contraction and maternal heart rate value. So you can also enter a lot of other parameters which you needed during the intrapartum and postpartum phase, like cervical dilatation, descent of head, BP and all. So it can automatically generate digital partograph for you. You can take the printout of the filled partograph and keep it for your record. You can have the checklist, pre-delivery checklist, post-delivery checklist. It has the whole antenatal related information which you can enter and generate your own case sheet. It has the Robson classification, APGAR score. You can calculate everything on the tablet. You can also take the digital consent of the patient in the tablet itself. You can have I'm sure a lot of hospitals have the computer on their nursing station where they can look at the centralized monitoring all the patient together in one shot. It has a delivery form placenta. So what I'm trying to say, starting from once a pregnant woman get admitted to a hospital for a delivery, till she get discharged, you can make your whole intrapartum and immediate postpartum process paperless by just adopting this product. And you can just take the printout of the filled case sheet for your record. And your data gets saved up to 15 hours for 15 years. And you can access the data at any time for all your statistics, reports, and any other purpose. So for example, doctor application. So now we know that you're all not always in the labor ward. So you can have the application in your phone and you can always access the data wherever you are. So you are traveling or at home or sitting at OPD, you can always see what's happening in the labor ward. The dashboard, you can always access the data at any point of time. You can filter out with the dates, you can filter out with the place, you can take the printout of case sheet, you can take the printout of traces at any point of time. And it just open on any computer. It works on browser, you can take printout with your existing A4 printer. This is how the centralized monitoring looks like. So let's suppose if you have a bigger labor setting where you have more than 10 labor bed, and you have the 10 devices. So you can actually have a look at the 10 patient together in one shot on the centralized monitor. So now, according to the usability side, we also have these stands where you can place, mobility can come into picture. You can have the bigger stand which also includes A4 printer. You can have another tablet, A4 printer. So all these, we have brought the modularity considering the hospital requirement. So you can select what you need based on what is your requirement. So this is what we are working on, and we're working on this since last 5 years. And a lot of, I would like to thank all our partners and supporters who have helped us in this journey in terms of funding, in terms of pilot studies. And this is completely a new innovation, and we have started commercialization of it. And I would like to thanks again the Kerala and the Thrissur Society for giving us the opportunity to present this here. So I would just stop here, will not take much time. Thank you, everyone. So Dr. Reshmi, I will hand it over to you.
Okay, thank you, Mr. Arun, for that new concept. And so we'll move on to the next panel discussion on high-risk obstetrics. And to chair the panel, we have none other than Serena Madam, Dr. Serena Gilvas, Professor and Head of the Department of Jubilee Mission Medical College. As we all know, she is a wonderful teacher and excellent clinician. So she will be leading the panel on high-risk obstetrics. And to attend as the panelist, we have a very great collection of consultants from different parts of Thrissur and Palakkad. Dr. Meera Ravindran, consultant in Daya Hospital. She, Meera Madam has been with us in medical college. We still remember her classes and all. An excellent clinician and a teacher, wonderful teacher. Dr. Reena Ravindran, additional professor, Government Medical College, Thrissur. Madam is also a wonderful teacher, an excellent clinician. And next is Dr. Bindu Menon, Professor of Jubilee Mission Medical College. She has been heading the emergency. She's an MCALS trainer too. And then Dr. Jita S. and two youngsters, newcomers, but consultants, and Dr. Jita S., who is an assistant professor in Amala Institute of Medical Science. And she has been an alumnus of Government Medical College, Thrissur. Dr. Shamala, she is a consultant from Palakkad, Palana Institute of Medical Science. Welcome all of you to the panel. Over to you, Madam, Serena Madam.
Thank you, everybody. At the outset, let me thank Arun for sponsoring this program and also for enlightening us on his beltless portable fetal monitoring device. And friends, I must tell you that if you are to sit and spend some time with him, you will understand more about it. Probably, Arun, you should be giving one of your contact phone numbers or something so that those who are interested can call you up and then you can talk to them and explain to them. Because once you understand it, then you will understand how useful equipment it is.
Sure, Dr. Serena.
Yeah. Now, coming to our conference for the day, we are having today a panel on the President's theme. And if I am to sum up Dr. Ambujam in just 3 words, I will say she is an all-accommodating, pleasant, and an apolitical person. If all the while that I have known Ambujam, I have found that she's such a pleasant person to know. She has got no airs about her. And she, when I really said that all accommodating, she'll put up with any situation with a very pleasant attitude. I think that takes a lot of on a person's character to say that. And it is a great pleasure, Dr. Ambujam, that we are to place a tribute to our President, Dr. Ambujam. We dedicate this panel to you. Coming to my esteemed panelists, we have none other than Dr. Meera. You all know she's from Daya. Dr. Bindu, who's from Jubilee. Dr. Reena from the Trichur Medical College. Dr. Jita from Amala, and Dr. Shamla from Palana. Okay? Now, I have taken just 3 cases, but we will go into depth. And I must also tell you something, that these are 3 real-time scenarios. It is not that I have fabricated anything. It is 3 real scenarios which we have gone through. Now, here is a lady. She's Mrs. Y, 23 years old. She's a primey. So she's a young primey, married 1 year. Her LMP on 10/2/20 and her expected date on 17/11/20. She was referred to us at 36 weeks with a recently detected hypertension. Okay, just recently detected. She is not on any antihypertensives from that institution. When we received her, the patient was conscious, she was icteric, she was jaundiced. Okay, her BP when we saw was 140/94. Per abdomen findings, uterus was about 36 weeks. When I went back on the old chart, her outside scans done at 11 weeks, 20 weeks, 31 weeks were all normal. Okay, so she's had a very uneventful time until now. Then we quickly did some investigations, and the investigations were hemoglobin of 12.6. Her platelet was 102,000. Her creat was 1.5. Her urea 46. Bilirubin 6.8. Direct was 4.76 and indirect was 2. SGOT 92, SGPT 121. Her ALK phos was 617. Her protein was 5.3, albumin 2.8, globulin 2.5. Her GRBS was 70. Urine albumin was trace, and the protein creat ratio came as 0.62. We did an ultrasound immediately, and the ultrasound said that she was 36 weeks, single intrauterine live fetus with the normal Doppler, and the ultrasound of the abdomen was also normal. At this point of time, Dr. Meera, you're there, I can see you in front of me. You can take this on. What do you think? What all do you make out of this case first?
Hello, madam. Good evening to everybody. From hearing the history and the available investigation findings, I thought of it could be AFLP, because she had initially it was an uneventful pregnancy. Later there is increase in the BP and gradually icteric, and then the lab findings, thrombocytopenia, then creatinine increased, bilirubin it is about 6, which is also increased, and the SGOT, SGPT more than 70. Then the GRBS become 70 only. That means there may be hypoglycemia, and protein creatinine ratio is a bit increased. So I thought it could be AFLP, or we have to think about a differential diagnosis also, like HELP syndrome.
Anything else? Any of the others would like to contribute to what Dr. Meera has said? I agree with what she has said, that the BP is 140/94. So it is just slightly raised. The protein creat ratio is 0.62. So it becomes pre-eclampsia. There is no fetal growth restriction, nothing. The platelets show a decreased value. A creat is slightly raised. Her bilirubin is raised. Her SGOT, SGPT, we give it significance for SGOT, SGPT when it becomes double the normal value. So it is more than double. The ALK phos is raised. And then, as she said rightly, the GRBA, there is evidence of hypoglycemia. And yeah, that's about all that I can make out of this. Anybody wants to add on to this diagnosis, what Dr. Meera has said?
You can also think of hemolytic uremic syndrome because
Very
the
good.
RFT is deranged.
Yes.
And hemolysis by evidenced by the raised liver enzymes.
Okay.
And
Anything else?
thrombocytopenia, again TTP, thrombotic thrombocytopenia.
Thrombotic thrombocytopenia. Then anything else?
Madam,
Yes.
not a,
Erana?
probably it may not be viral hepatitis because the bilirubin is only 6.8.
Oh,
and
very good. But what else did you want, Bindu? What else did you want?
a further investigation, I would like
Certainly,
to have
I would like to do some more investigations. Right. What
coagulation
else?
profile.
Okay,
Coagulation.
fine. Very good, Bindu. Then anything else?
And the viral markers also, for the sake of completion, she is jaundiced.
Yes.
Rule out.
Rule out. As Meera was saying, we have to rule out other things also. And as you said, we must rule out viral hepatitis also in this scenario, right? I agree with you.
So viral hepatitis, the STP liver enzymes will be very high. So, but sake of completion, we have to do the viral markers.
Beautiful. Very good. So as Dr. Bindu said, one point against the viral hepatitis is in viral hepatitis, the SGOT, SGPT will be in thousands, 1,000, 2,000, 3,000, 6,000. It will be like that. That's what normally happens in viral hepatitis. Yes, I fully agree with you. Anything else, Bindu, which strikes you as very important in this investigation so far?
LDH and
hypoglycemia.
Ma'am, we have to do an LDH and a
Very
peripheral
good.
smear to
Very
rule
good.
out
Very good.
hemolysis.
Very good, Shamla. Right. Then
The serum uric acid also, ma'am. Serum bile acids, ma'am.
Why did you think of obstetric cholestasis?
It is
But she
unlikely
got
the patient is not having a history of pruritus,
No
but
pruritus, so it's So bile acids is actually superfluous. If for obstetric cholestasis, the investigation is bile acids, as she rightly said. But this, she has got no pruritus, nothing. This is all that she was. Okay, so we'll see what happened. Okay, exactly like what you said. As Meera said, I too thought of AFLP first, then a preeclampsia with help. Yes. But the advantage in those two first diagnoses, you don't have to differentiate. Do you know why?
treatment is termination of pregnancy.
Treatment is not just termination, but immediate termination.
Yes.
In both these conditions, it is immediate termination. But whereas if it is a hepatitis, probably I would wait for termination. You understand? Because hepatitis, there is acute necrosis of the liver, so don't ever think of terminating then. If you can wait for a little time to tide over the hepatitis, that will be the best. And we should also think of a dengue and a leptospirosis, right?
Yes.
There's no history of fever. But
yeah, there is no history of fever, I agree. But if you're asking for dengue, we should have asked for what, Reena, what investigations would you have asked for?
What's it known as?
You'll have to check the antigen within the first 2 days, NSI antigen.
Yes, yeah.
And if you want to check the dengue antibody, you can check it after a week. Then you'll have to check for dengue antibody. Leptospirosis, we don't check for antigen. We check only for antibody. You understand? So this is all what, so we went about this. And as you said, we checked out the viral markers. We had to have a broad vision. So all the viral markers, dengue, leptospiro, everything was done. Then I heard Dr. Meera say that you should do the coagulation profile. Yes, the PT was raised, the INR was raised, the APTT was raised, the fibrinogen was only 105. See, if I had not asked, I would not have known. Then what I did was I repeated the RBS and that was 70 again. So now, Dr. Meera, you would like to tell me something?
Yes, then the diagnosis may be confirmed as the AFLP.
As AFLP. So we confirmed the diagnosis, but you want to add on one more word to that? AFLP with?
Coagulation.
Yes, with a deranged coagulation, okay, or coagulation failure or whatever. Because her fibrinogen is only 105 and all her values are raised. So that was what the diagnosis was. So the AFLP with coagulation failure. And when I did the PV to cervix was uneffaced, also was closed. How will you manage? Yes, Shamla, you want to give me some ideas to how I would manage this patient?
We have to terminate by immediate termination is preferred. So we have to consider cesarean section. General anesthesia is preferred over regional anesthesia. The anesthetist, intensivist, and hematologist, neonatologist all should be informed.
Very
and
good.
blood and blood products should be cross-matched and kept ready.
Very good.
And we have to terminate by an immediate cesarean section, ma'am.
Why not a vaginal delivery? Is AFLP a
She's a
contraindication
primey.
to vaginal? Yes.
No, ma'am. She's a primey and her Bishop score is 0/12.
Yeah.
So like.
Her Bishop score is 0 actually, if you see. So she is going to take a long time. And what did I say? Sometime back, immediate termination. It is so
Termination.
important for an immediate termination. And seeing such a poor PV, we decided to do a section. And as she rightly said, we got, you must get at least a gastro opinion, at least for the records. You should have a gastroenterologist. If you don't have a gastro, get a physician, get somebody. Cesarean was planned for incision, Shamla?
Transverse incision can be done. It depends upon the preference of the surgeon, ma'am.
Anybody else has got anything?
No, midline incision. Preferably the patient is in coagulation failure.
He's in coagulation failure, you know. So
Go
if
by
you go by,
midline
correct. You will have more bleeding. Okay.
Midline and put in a drain.
Yes, very good. Excellent. Excellent. So anesthesia, we prefer a
general anesthesia.
Yeah, we don't like to have an epidural because she's in coagulation failure. Any coagulation problems, no regional anesthesia. So we went for GA. Yeah, that is how we did. The blood bank was informed. The blood product started. In the ROTEM, they told us to give us 8 bags of cryo. So we just gave her 8 bags of cryo. And on the table, we found that the uterus was very flabby. So we did a Heyman suturing. And as Reena rightly said, you must, when you close the abdomen, when we are doing in coagulation failure, you must keep a drain and then only close. Okay, right. Then before we did that, we did her ABG. Can anybody read the ABG for me? Bindu, you'd like to read? Anybody wants to read what does the pH tell you? 7?
Madam, here the pH is 7.1. So that is low. The normal is between 7.36 to 7.44. So she is
so 1 minute, Bindu.
And PCO2 value is normal 36 to 44. That is also low. Partial pressure of carbon dioxide. And bicarbonate normally is 22 to 26. That is also low. When the pH is low, PCO2 is low. So it's most probably a metabolic acidosis.
Very good. Very good. She was actually in metabolic acidosis. Yes, correct, Bindu. Can you hear me?
Yes, yes.
Yeah. So, and
hemoglobin is, okay.
Yeah. So after that, post-operatively, what do you think I should do, Bindu? You want to tell me something? What are your post-operative orders after this? We did the section. We did a midline incision. We did under general anesthesia. We kept a drain. And then we checked out our ABG. It was metabolic acidosis. Anything else you want to tell us? Post-operative management, anybody can tell me.
To be on a mechanical ventilation.
Patient should be kept in ICU.
Yes.
Intensivist, a multidisciplinary approach should be given to the patient. And
you have to give her all the supportive.
She must be on a mechanical ventilation too, isn't it?
Very good, very good. And anything else about anticoagulants for her, Reena?
Only when
when it gets corrected. It's already deranged. It has to be corrected. You can't be putting her on heparin now.
Very good, very good. So this is what we did. We shifted to the multidisciplinary ICU. Multimodal parameters were checked out. The vitals, we kept a check on the output because you remember her renal parameters were a little deranged. So we checked the output. We gave her antibiotics. We gave her oxytocics because you remember she had flabby so we gave her that. Anticoagulants I put, and exactly as Bindu said, only after you have corrected, maybe on the 4th or 5th day, you may have to add on an anticoagulant. Till then, don't do it. We repeated the deranged investigations, INR, fibrinogen, platelets, sugars, LFT, RFT. We repeated the ABG, all the supportive measures. As Reena said, we gave a ventilatory support. We thought we would have to give a vasopressors, no problem. And after you wean them out after 2 days and 3 days on the ventilator, remember to give them to use incentive spirometry. Very important. Otherwise, they can go into post-operative atelectasis. Okay, so we did all that. And don't forget the DV stockings. Yes? Yes, we must remember. So we have to think wide. We have to think of all her problems. the oxytocin, the DVT stockings, the low molecular weight after the coagulation profile, repeat the investigations which were abnormal, etc., etc. And then, Bindu, when we looked at that ABG again, it is pH was 7.28, carbon dioxide 34.3, PO2 was 95, and bicarb was, so it is slightly becoming better. Okay, it is slightly improved.
Slightly improved, but still she is in metabolic acidosis.
Very good, Bindu, very good. So I'll just tell you all a few things for those of you who are listening to what Bindu was telling you. So this was our diagnosis, AFLP. To collect the blood for ABG, you must collect from an artery. It's not venous blood, okay? You must take from an artery, the radial artery or femoral artery, wherever, from an artery and in a heparinized syringe. That's how you collect the blood for ABG. In all patients with acute collapse, sepsis, etc., you must do an ABG. Now, as Bindu said, the pH if you remember just this one thing, the pH is 7.3545. So remember it is 3545. Okay. So anything less pH is, as Bindu said, it is acidosis. If it goes beyond 745, it is
alkalosis.
It is alkalosis. Very, very simple. Then the next thing you look at the bicarb. I'm sorry, not the bicarb, the carbon dioxide. Carbon dioxide, again, it should be around 40 millimeters. Again, keep it as 35, 45. Do you understand? So you check the PCO2, it should be around 35, 45. Carbon dioxide also, so around 40. Now, the bicarb, as she said, just don't think of a range. Think of just one value, 24 milliequivalents. So when the bicarb falls, it is metabolic acidosis. You all agree?
Yes.
Yes. And now when I look at the carbon dioxide, now I'm looking only at two values, the pH and the carbon dioxide. If the pH drops, it is acidosis. If along with that, the carbon dioxide also drops, then both are moving in downward direction, same direction. It is acidosis, same direction, it is metabolic acidosis. You got it? If the pH is dropped, it is acidosis, but if the carbon dioxide is more than 40, it is moving in opposite direction. You saw that? This is respiratory acidosis. Simple. Same thing, you go back to carbon dioxide. I mean, you go back to the values being raised. If the pH is raised, it is alkalosis. Okay. And if the carbon dioxide is also raised, it is metabolic alkalosis because both are in the same direction. Got it? If the pH is raised and if the carbon dioxide is low, then what is this? It is alkalosis, but what alkalosis?
Respiratory.
Respiratory. Remember, respiratory is opposite direction, like your inspiration, expiration. So when the pH and the carbon dioxide move in opposite direction, that means it is respiratory. To tell you whether it is acidosis or alkalosis, look only at the pH, 35, 45. Okay, very simple. So when the pH decreases, it is acidosis. It could be metabolic or respiratory. If the pH increases, it is alkalosis. It could be metabolic or respiratory. Do you understand? If both the carbon dioxide and the acidosis are in the same direction, then you'll have to think of same direction as metabolic. If the pH and the carbon dioxide move in opposite direction, it is respiratory problem. Either it is acidosis or alkalosis. Now that's what I have said. And the bicarb, if you have to take the bicarb alone, it is actually, it should be 24. If it is less, it is metabolic. Now I'll just go back for you to see this. Now look at this first value. Look at that, pH is 7.1. So what is it, Shamla? Acidosis. Carbon dioxide is also low. So that is also
going in the same direction.
Metabolic acidosis. And to add on to that, the bicarb is also low. So it is definitely metabolic acidosis. Got it? And then you look at this, it is slightly better. 7.1 has become 7.28. So the acidosis is improving. The carbon dioxide also from that lower value, it has become 34. It should be around 40. I told you 35, 40, 35, 40. Do you understand? And the bicarb from that low value has now become 17. Again, she requires correction to become 24. Do you understand? Yes, I hope you all have understood. Right. So coming to what we were saying. So when AFLP, I'll just tell you a few words. Acute fat, it is called acute yellow atrophy or acute fatty metamorphosis. It's a life-threatening complication. It occurs very rarely, 1 in 7,000 plus 1 in 16,000. It normally occurs in the third trimester, immediate postpartum. The risk factors are maternal age, multiparity, male fetus, multiple pregnancy, underweight, and preeclampsia. Probably in this case, it must have been the preeclampsia. It is a liver disorder unique to pregnancy. It's not seen in any other form. It is seen only in pregnancy. It is an obstetric emergency that leads to fulminant hepatic failure. Okay. The acute fatty liver is also called acute fatty metamorphosis, acute yellow atrophy. It goes by so many names. Recurrence in subsequent pregnancy is uncommon. It's not so common. Okay. The immediate diagnosis is important. Along with that, they normally complain of all hepatic problems, nausea, vomiting, anorexia, lethargy, abdominal pain. Sometimes it could be epigastric pain. Sometimes they could have pruritus. They could have ascites, sometimes progressive jaundice, and even death. That's why I said you should immediately diagnose it. Occurs around the second half, around 34, 37 weeks of pregnancy. Based on the clinical features plus the laboratory findings, what I told you some time back, hepatic imaging is not required. So you know what hepatic imaging is? You'll have to ask for what is the obstetric ultrasound plus abdominal ultrasound. That is, they'll image the liver also for you. Otherwise, normally they don't image the liver. You understand? So hepatic imaging is not reliable in confirming. But sometimes we may have to do when you think of a differential diagnosis of a hepatic, of a hematoma, subcapsular hematoma, etc., you may require further imaging. You don't have to do a biopsy also. It is often associated with acute renal failure in 60%. That is why our patient was showing 1.5 creat. And we counseled her about dialysis, but she didn't require it because we quickly terminated her. We thought of all the differential diagnoses, we ruled out everything, and she can go in for a hepatic encephalopathy if you keep quiet and if you relax on it. Preeclampsia is associated in 50% of the patient. But the best thing is, even in the most severe case, even the entire liver has undergone fatty atrophy, there'll be complete recovery of the liver and the kidneys after delivery. There's complete recovery, and recurrence is uncommon. Associated complications, you can go for PPH, renal failure, hypoglycemia. You must correct the hypoglycemia. DIC, which our patient had. Sometimes there could be pancreatitis and pulmonary edema. Okay. And as Bindu and always saying, the serum transaminase is always low. It will be high, but less than 1000, not so high. Bilirubin also will be high, but it will be less than 10. There could be leukocytosis, but hypoglycemia is very, very pathognomonic. And if you see an elevated ammonia, that means she's going for encephalopathy. Okay, because I told you she can go for renal failure and encephalopathy, thrombocytopenia, coagulopathy, renal dysfunction, etc. A multidisciplinary approach, gastro, nephro, anesthetist, get everybody involved or whomever you want. Prompt delivery is a definitive treatment. And as Shamla rightly said, she's got a poor Apgar, don't wait for a vaginal delivery to take a long. Supposing she was 4 or 6 centimeters, give her a vaginal delivery, no problem. So induction is okay, cesarean, avoid regional, prefer GA. Correction of hypovolemia, hypoglycemia, transfusion of products. Recovery is seen within 48 to 72 hours. Severe disease is associated with high mortality, and management of renal failure and hepatic failure. Mortality up to 10%. It is due to hepatic failure, renal failure, and coagulopathy. And the mortality depends upon whether she's in a tertiary care center or not. You understand? It's very important that when you diagnose a condition like this, do all the investigations and refer her to a tertiary care center because the mortality is low there. They say you can reduce it even 10% the mortality, otherwise you can lose the patient. But most of the times we lose the baby. Perinatal is as high as 85%. So early diagnosis is imperative, maternal and fetal mortality and morbidity. Now we come to the next case. Okay, she's a 29-year-old. She's an old known case of a seizure disorder on phenobarb. She's a para 2. She had a cesarean outside. She was sterilized also because she was a previous cesarean. They have done the cesarean. On day 4, she was referred to us with fever spikes. Okay, 102 degrees. She was also breathless. And when we checked the SpO2, it was 90%. Okay, her temperature was 102. Her respiratory rate was 46. Her pulse rate was 126. Her BP was 110/80. There was abdominal distension. She's the 4th post-operative day. Okay, abdominal distension, bowel sounds were sluggish, severe tenderness, guarding. There was severe guarding in the right iliac fossa. Hemoglobin was 10 grams. The total count was 12,000. Electrolytes were normal. LFT, RFT normal. What else do you want to know from these? Jita, you're there. You can take it on.
Yes, ma'am. Good evening, ma'am.
Yes.
So, seeing this case scenario, she's a post-LSCS patient on day 4, and she is having a high-grade fever with tachypnea and tachycardia. And the first diagnosis that comes to my mind is the puerperal pyrexia. And you have to, from the history itself, you have to check for the other causes for puerperal pyrexia. From the history, ma'am, I would like to know about the duration of the symptoms and regarding whether she has having other symptoms like any foul smelling discharge or any about her bowel habits, any urinary symptoms like that, and whether she is having any discharge from the wound. And on examination, actually whether she is conscious oriented. Then I would like to know about her abdomen, the wound, whether it is okay, or then whether the uterus is properly involuted. I would like to do a perspectum and a vaginal examination. Then
okay.
Coming to the investigation, she is likely, the features are mainly suggestive of a sepsis. So I would like to have more investigations also.
What investigation? I'm asking you, what do you want? The wound was quite okay. This is all the information. She's a 4th post-operative day. The wound was quite okay. She had abdominal distension, bowel sounds were sluggish, severe tenderness, and there was guarding. And these were the findings. You want, what are the investigation? You ask me and I'll give you.
Now, first, we have to look for an ABG and a serum lactate. Then the total count is not, the total count is 12,380. Then I also like to know about the differential count. Then whether she had any culture sensitivity, the blood culture, urine culture, and whether a vaginal swab has been taken. Then also I would like to have her chest X-ray done, and any ultrasound abdomen and pelvis.
Yeah. So as Jita rightly said, the first comes first. My first investigation was an abdominal ultrasound, because what is staring at me is the abdomen. Do you understand? Because she had abdominal distension, and so just as Jita had said, we did an ultrasound. The ultrasound, this was the finding. It showed a postpartum uterus. The ovaries were not imaged separately. Maybe it was behind. A collection with septations with internal echoes were noted between the anterior abdominal wall and the uterus. And they told me it is about 310 cc's. And the adjacent tissues all appeared echogenic. There was also free echogenic fluid in the abdomen. And they also told me, madam, there is both the the pleural effusion, there is minimal on both things. And there is hyperechoic kidneys also. With the above findings, what is your diagnosis? Jita, you want to continue with this?
So the findings are suggestive of puerperal sepsis, probably a endometritis with a pelvic collection. I would like to start her on.
Can I ask somebody else, Dr. Meera, with this, yes. What is your diagnosis, Meera?
See, there may be, since it is a previous cesarean case, there may be difficulty in doing the cesarean sometimes, maybe additions like that. And she had already sterilization. So sometimes there may be slipping of the suture, maybe some slow leak, which may be causing the collection sometimes, or additions. Again, the hemostasis may not be adequate sometimes. And so that may be the reason why there is collection. Another thing I thought of is see any foreign bodies, anything like that sometimes.
Very good, very good. We must think big.
Then sometimes unknowingly you may be injuring the intestine, especially if it is a previous cesarean with the addition sometimes. So these.
Anybody else wants to add on to what Meera has said? Bindu, you got any difference of thought? Reena?
Ma'am, because you said right iliac fossa tenderness, we could even think of an appendicular abscess, which is not recognized probably during the cesarean, or it's a hematoma which just got infected now. And as ma'am said, it could be a forgotten pack or sponge.
Yes, yes, very good.
So it could be.
Bindu?
She's having collection. Echogenic free fluid in the abdomen. So there is peritonitis. Features of peritonitis is the plus intra-abdominal abscess maybe. She is in sepsis because all the features, she's having tachycardia, fever spikes, and tachycardia, tachypnea, everything, plus the collection inside the features of peritonitis is also the paralytic ileus, and plus pleural effusion, hyperechoic kidney. So she may be progressing. The sepsis may be progressing.
Very good. Very good. Very good. I liked your thought. I like the word which you used. Yes, now she's got peritonitis. As Meera said, she may have had a hematoma which got infected. Could be anything. But as of now, it is not just plain infection alone. It is not just puerperal fever alone. It is peritonitis. Because I said abdominal distension, I said guarding rigidity, I said the bowel sounds are sluggish. The scan shows a free fluid plus an encysted fluid, everything. With this, Bindu, you want to carry on? What do you want to do for this patient, Bindu?
Madam, this patient, this is a case of sepsis, sepsis. So I would like to start the surviving sepsis campaign. Immediately, I have to start the sepsis management in view of. And plus, she is having post-LCS collection. She has to be, collection has to be drained, whatever infective. Before that, I would like to do the blood culture, urine culture.
Very good. Okay.
Antibiotics.
You want a urine culture? No, no. We must not tell all the investigations. Do you want a urine culture or do you want a blood culture for this patient?
Blood culture. When you are putting the line,
there is no urosepsis here. It is only, yeah. So you want a blood culture. I fully agree with you. Right.
And start after taking the blood flow culture, immediately we have to start the broad spectrum antibiotics.
No, but what about what Jita said about a vaginal swab, high vaginal swab? You want that?
That yes. You can take.
Yes,
yeah.
Whatever we can add on. Yes. Then what else?
As a part of sepsis, we have to do the serum ABG. We have to do.
Very good.
Is very important.
Very good.
And she is in sepsis. We have to start the IV fluids also.
Yeah.
So we have to give the large doses of IV fluids.
Okay.
And we have to take the patient for. After starting all these things, we have to.
But Bindu, that when you say fluids, no, remember the fluid, you have got to give a fluid help to these patients, but don't give more than 30 ml per kilogram body weight, because if you give too much, you can go for pulmonary edema also. Okay. So you've got to give a fluid resuscitation, antibiotics. And as Bindu rightly said, we must take a culture. And as Dita said, we must take a high vaginal swab. But the important management, yes, Reena, you want to tell me something more?
Yeah, you have to do a laparotomy.
Yes, that is what I wanted you all to say. When there is peritonitis, just take home one message: peritonitis, laparotomy. Peritonitis, laparotomy. Don't try to aspirate this, because they are telling us that it is just a 310 collection, it is fine. But they are telling us that there is free fluid. That means there is generalized peritonitis. There is abdominal distension. There is bowel sound sluggish. There is tenderness, guarding, rigidity. So when there is peritonitis, don't play about with the needle and aspiration and antibiotics. You must do a laparotomy. Okay. So postoperative sepsis with peritonitis is my diagnosis for this patient with that ultrasound findings. Okay. And as Bindu said, investigations we send for culture. Lactate you must do. Lactate is very, very important part of investigation. It's part of the surviving sepsis campaign. So you will have to check out the lactate. ABG, now you all are professionals in that. Antibiotics, when you hit hard, go for the highest. See, when you give a prophylaxis in a cesarean, you need give only a cefazolin. But when there is severe sepsis like this, which can go for mods, okay, you must hit hard. And that is why you should save your antibiotics for this rainy day, which is this patient. You understand? So what next after this? Bindu, you want to say anything more? Reena?
So,
yeah, okay. Bindu can carry on.
No, madam. Reena, you carry on.
Reena, paranya, Reena, endha cheya?
He has to be worked up for a laparotomy, and
correct.
Under full antibiotic cover, you have to do it, and most often this is done under GA. Drain the pus. Look for whatever this means. You already found a hematoma on the scan. Probably you'll find a pus or whatever is the cause for that bleed. Let it out, and of course, as we said, you have to keep a drain here again.
I agree. But Reena, let me ask you, you said you want to counsel this patient something more?
Yeah, definitely.
What is it you want to counsel? One is the scan findings. What more do you want to counsel?
She might need a hysterectomy, ma'am.
Yeah. Very good. Who said that? Who said that? Shamla. Very good. Because, you remember that day when we are talking about those medico-legal cases, etc. Because once I might give a GA, right? And once she goes under and she requires a hysterectomy, I'm in a mess. I can't do it without her permission. And look at my scan findings. She's got a 310 collection on the anterior wall of the uterus close to the abdomen. Do you understand? Right. Yes, I agree with you, Reena. She was kept nil per mouth. IV fluids were started. She was posted for a laparotomy. And let me tell you, this is a real-time scenario. When I decided on laparotomy in the morning, she was not so bad. But just before they intubated her, no, she became so dyspneic. I thought she was going to die. Okay, I was so scared. And so I went up to the family and said, no, a patient before surgery. Anything can happen, even death on the table. She's extremely bad. She's become very, very dyspneic. So I said that. And then what are you planning? As you said rightly, on the table, there was purulent free fluid, encysted collection anterior to the uterus, and it was communicating with the uterine cavity, that encysted collection. So now what? Yes, Reena, you want to tell me?
She needs a hysterectomy because leaving the uterus behind is going to create more problems.
Absolutely. So whatever toileting you do, whatever you let out, because this I saw it was communicating with the uterine cavity. So fortunately, when the patient became bad, I ran up and I told them, everything I told. And it really happened that way. We had to do a hysterectomy. We were forced to do a hysterectomy. The tissues at that time are very, very friable. The abdomen was toileted and drain kept enclosed. As Reena said, keep a drain. She kept it when there was a coagulation failure. She kept it when there was a sepsis. Patient had a very stormy post-operative period, but then she recovered beautifully. Okay. So let me tell you a few words. Persistent hypotension, despite adequate fluid resuscitation requiring vasopressors to keep the MAP more than 65. Okay, that is sepsis. And when you see that there is a persistent hypotension, that is, there is evidence of sepsis, that means there is a microbial organism invasion, whatever, wherever it is, whether it is following an instrumental delivery or cesarean or whatever. And you find there's fever spikes, etc., and there is a persistent hypotension. That is called septic shock. Okay, this is septic shock, persistent hypotension. And you have given her, as I told you some time back, 30 ml per kilogram body weight is the amount of fluids that you give. Even after that means I thought of a pre-renal. And then also it is not coming up. That means there's a septic shock. And the serum lactate, normally it's more than 4 millimoles. But according to the new sepsis guidelines, they start thinking of it from 2 onwards. So I told you must ask for serum lactate. And I told you 3 things. We will do the blood culture, as Bindu said. We will take a vaginal swab, as Jita was telling you. You must do the lactate, only then we will know what it is, to what level it has gone in for. And you saw that she might have metabolic acidosis also, must do an ABG, etc., etc. And we'll have to proceed with that. Now, this is actually the SOFA score, or the sequential organ failure. You know that when there is sepsis, okay, it can go in for multi-organ dysfunction. And when it goes for more than 2, we call it MODS. So when there is more than 2. Now look at this, the SOFA scoring, okay? Look at that last column. I'm not talking about anything else. I'm talking about that last column. That think of that column 4 when we give a score of 4. When the respiration FaO2, the FaO2 is nothing but your partial pressure of oxygen, arterial. And the FiO2 is the oxygen of the inspired oxygen. Okay, the fraction of oxygen in the inspired air. Now, for example, in the atmospheric air, the oxygen is only 21%. So atmospheric air, if you're going to give, it's only 21%. If you want, you can increase FiO2 by giving added oxygen, etc. Now, if that ratio is less than 100, she's an ARDS. Do you understand? The normal value is between 300 to 200. The moderate is between 200 and 100. But if it is less than 100, it is very bad. She's in severe ARDS. So 1 organ down. Coagulation failure, less than 20,000. Namalde patient adu undairunilla. As we had 1 lakh. Liver, you will find that if the bilirubin goes up, then of course all the SGOT, SGPT, all that will come and the hepatic failure sets in. Cardiovascular, she's got persistent hypotension. The fluid resuscitation has not helped. You've had to give. And in sepsis, the best vasopressor is NORAD. And then if there's a cardiogenic component, you can add dobutamine. Do you understand? And then, of course, if you want to whatever, sometimes you have to give dopamine, etc. CN has a GCS score. If it is low, it's bad. Okay. And if the renal creatinine is more than 5, it is very bad. You may have to counsel for it. So this is just to tell you, all the lesser forms are the 0, 1, and 2, 3 scores. Okay. So this tells you that any 2 organ dysfunction is called MODS. So now first we had the 1 hour bundle, the 6 hour bundle. Now all that is gone. Now it has become a single step. What do we do at the first hour? We must send for the CBC because that is our day-to-day monitoring, Maklam. See, when you do a total count, today it is 24,000, tomorrow it is 28,000, day after tomorrow it is 32. Your sepsis is not settling down. You can't be looking at your lactate. You must do the CBC. You understand? Lactate will help you to come to a diagnosis. The procalcitonin, you know, the procalcitonin is a wonderful marker. If you've got it in your institutions, it's very good. Supposing you've got a patient who's in shock and you don't know the cause for shock, then just ask for procalcitonin. If it is more than 10, she is in septic shock. One diagnosis, septic shock. Now you know the meaning of septic shock, which is persistent hypotension. Sepsis, severe sepsis with persistent hypotension. Then of course the blood cultures and whatever. If it's a respiratory problem, then you'll have to take the sputum. If it's a urinary problem, you take the urine for culture. Where if it's from the wound, Gita was asking me, how was the wound, madam? I did not mention because the wound was quite good. But if there is a wound infection, take the swab from the wound.
One thing
And
I
she
thought
said
of
you take a high.
was you said she's on phenobarbital. So I was thinking whether it's an aspirational pneumonia or something, whether she had some seizure.
Okay,
like that. It was not.
Okay. But abdominal findings were what was staring at you. She was quite,
cannot be explained by that.
Yeah, correct. That cannot be explained. So you must take an X-ray chest. Your CT scan is, if applicable, you can do it. Other imaging tests of suspected body systems and possible, so we don't know the possible source of infection, you can go on for other investigations. But the treatment is broad spectrum. I said hit hard. You can give IV fluids, crystalloids meaning normal saline and RL. Vasopressors, now you know it more than me. Oxygen supplementation, whenever you think an ARDS, please give a mechanical ventilation. Sedatives, you'll have to give her, supposing she's in pain and you're not intubated her, you'll have to give her whatever. Nutrition supplement, you'll have to give her IV fluids because if you're keeping her nil by mouth, you must give her IV. You understand? Then surgery, etc. So these are all the things. You will have to give them oxygen. Remember to do the blood culture, the antibiotics, hit hard, I said. Fluid challenge is important. The lactate levels are important. Check out the urine output because sometimes you can go for renal failure and sometimes in the ICU itself, we give them a dialysis. Do you understand? So antibiotics, which are the most sensitive, you'll have to attack a gram-negative, gram-positive, and an anaerobic. So if you ask me like this, a sepsis, I will straight away go for something like Tazobact, piperacillin, plus that will take care of the gram-positive. Aminoglycosides will take care of the gram-negative. I might give her amikacin, I might give her metrogel also, I might add on. And then after the culture report comes, if she is doing well, continue the same. But if she has not been improving, and I told you the total count is going on increasing and she requires more supports of the respiration on the ventilator, then you may have to change according to your culture report. That's how you change, okay? Now, this is the last case.
Madam, one doubt, what about thromboprophylaxis? We should give, no?
Yeah, good thing you told me. There are a lot of other things you'll have to do, okay? You will have to, if the patient is conscious, you'll have to, I only said about the important things. Bindu, you have to give them everything, Amma. You will have to...
ulcer prophylaxis, thromboprophylaxis.
Yeah, very good, very good. You'll have to think of all these things. You will have to think of all the prophylaxis for the patient because you will have to give an omeprazole or a pantoprazole or a thing. You may have to give her anticoagulants. Do you understand? You may have to support her with giving anti-stress drugs. You may have to put in a rice tube sometimes. You'll have to aspirate. So all the supportive measures, oh, don't forget all that. Don't forget all. I only pointed, I can't do the whole thing on sepsis. There is also a place, let me tell you, though we say steroids, there is a place for a rapid steroid also. You can give hydrocortisone 200 milligrams per day for about 7 days if they are not responding to that sepsis. So lot of supportive. Yes, Bindu, I fully agree with you. Okay, this is the last case. She's a 31-year-old, first FTND, Gravida 3 Para 1 Live 1. Second was an ectopic pregnancy. She had an LMP and 9321 EDC. I only changed the dates, okay? She's married 7 years. She had irregular cycles, 40-45 days. We did a double marker on her. The anomaly scan was also normal. Double marker meaning the combined test NT scan. Anomaly scan was normal. She was a GDM, detected to have GDM. Her fasting blood sugar was 118 and this. And we started her on metformin and insulin also. In fact, this was, I should not say we, this was a patient referred to us and I'll tell you how it happened. And then 19-2, she delivered a live, the dates are wrong, okay? I purposely changed the dates. She delivered a live active baby. So there was nothing wrong till her delivery, okay? Suddenly, patient after the placental delivery collapsed. She became disoriented and the pulse was very feeble. The BP was low. There was no undue bleeding. So now what do you think? Anybody who wants to take it?
Yes, you have to suspect amniotic fluid embolism.
Very good. Very
or
good.
The differential diagnosis would be inversion, acute inversion uterus.
Why? Where is the inversion?
Immediately after delivery, delivery of the placenta.
No, but then you should see the inversion, right? No, I'm just asking you.
Yes, definitely. You have to see that. But sometimes if it is in the vagina, after the delivery,
very good. Very good. Then anything else you thought of? Very good, Meera.
Sometimes it could be a rupture uterus. Can be.
Very, very good. Excellent. It could be a rupture, and after rupture, there may not be much of bleeding. It's very difficult to diagnose a postpartum rupture. Okay, right. Anybody else wants to add on to that, what she has said? Bindu, do you have got anything else in your mind?
Embolism, pulmonary.
Very good. Pulmonary embolism, amniotic fluid embolism. Very good.
Yes, local anesthetic.
Endama? Very good. Excellent. 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 You should also, if you've given her a drug at that time, maybe there is a drug anaphylaxis, why she has crashed. Okay, you've got to think of a drug anaphylaxis. Yes, then?
She could have an supraelevator hematoma or
very good. Excellent. So in other words, it could be an incomplete rupture. Illa Shamla?
Yes, ma'am.
Yes, very good. You'll have to think of that. So we thought of all these things. Okay?
And she could also have an MI, ma'am, myocardial infarction.
Very good.
Spontaneous coronary artery dissection.
Very good. Excellent. Superb. 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 You have to think wide, okay? Because there is nothing here. After delivery of the placenta, she has had a feeble pulse, 70-40 BP, no undue bleeding. I do not know the cause. And she has collapsed. She has collapsed, okay? So these were the things we thought of at that time. Amniotic fluid, pulmonary embolism, thought of a rupture, did a drug, thought of a drug anaphylaxis, because we have had even a drug anaphylaxis with the Dynapar suppository also. I've had a patient who crashed in front of my eyes. Soon after delivery, we put in one in the rectum because we didn't want her to have the episiotomy pain. And suddenly she crashed. So we thought of a drug and we thought of all these things. Now, so these were all what ran through our mind. Then what Meera said, per abdomen, when I looked, there was no fundus. Okay. And then when we did a PV, there was a polypoidal mass filling the vagina. There was just minimal bleeding. That's all. So yes, so neurogenic. So it's a neurogenic shock, and that BP crash, everything which you saw was a neurogenic shock that she had. So now your diagnosis would be, Meera?
Inversion uterus, acute inversion uterus.
Inversion. Yes, Meera, you can take on. What will you do now?
Then first you correct the neurogenic shock. Simultaneously try
what will you do? What will you do, Amma, to correct the neurogenic shock?
We have to secure airway breathing and circulation for the patient, ma'am.
Okay.
And then we have to try
but
to
I did not say that the patient has got difficulty in breathing. So airway and breathing is fine. There's no problem. Do you understand?
IV
yes,
fluids.
Very good. So what she had was she required only IV fluids at that point of time and probably some vasopressors she may have required. Okay. So Meera, what else? You were saying something, Meera?
Yes, you can try for manual reposition of the uterus.
How do you do it?
Using this, immediately you can do
whatever you can do is IV fluid you hang at a height.
Okay.
Height you can, and then with the usual IV line, and then connect it to the this large more catheter, this bladder, which one?
Euro bag, you mean?
Bag. You can connect it to that so that you can rush the fluid.
Okay.
See,
yes.
You can use the vacuum cup also to hold the, keep the fluid coming out.
Okay.
So that, you can rush the fluid usually it may, I mean, hydrostatic, with the hydrostatic pressure, sometimes it may be, the uterus may be going in, and simultaneously you have to start this oxytocin to contract the uterus.
Okay.
Or by your fist, you can push the fundus of the uterus up, and simultaneously by manual combustion, you can keep the fundus in position, as well as along with that, you can start the oxytocin to contract the uterus.
Okay, you'd like to say some no's to us, what we should not do?
If the placenta is not expelled, we should
The
not try.
placenta is out.
Placenta is out in this patient, but very good, Shyamla. If the placenta is not expelled, what is it?
We should not try removal of the placenta before repositioning the uterus.
Why?
After, she will start bleeding torrentially.
Bleeding. So just now Reena said neurogenic shock. Now she'll have a hemorrhagic shock also. You understand? So better not to. But many times, you know what happens, Shyamla, when you don't put in that placenta, when you don't remove that placenta, the bulk is so much it won't go inside.
Yes, yes. So,
Reena, you would like
Yes.
to say something more, Amma?
No, it's actually can try manual replacement under ideally under anesthesia, because you're going to push it in. And if it's not possible, you will start using the hydrostatic pressure.
But tell me how you put the manual repositioning.
And that is the last, the center portion should go in last. It is the periphery that should go in first. That is how you push it in.
So the part which
comes from last goes in first.
Goes in last. Okay, that I agree with you. So the fundus is the last to go in.
Yeah.
Because that was the dimpling of the fundus was the first. So that will be the last to go in. Okay.
You start from the periphery and gently keep on pushing it towards the center.
Very good. Very good.
She is in the third stage of labor. Usually she may be on oxytocin drip.
Okay,
So
very
if the patient is on oxytocin drip, we have to
stop the drip initially.
The manual reposition is over.
Very good. Very good. So it's best to stop the oxytocin if the oxytocin was there, because it will tighten your ring. Then you can't reposition. Yeah. Geeta, you would like to tell me something more?
No, that is what I was thinking. First, you have to stop the oxytocin till we reposition the fundus, and then only after that, maybe you have to give some tocolytics also. Like if you have any difficulty in reposition.
Excellent. So you will have to stop the oxytocin and you'll have to give tocolytics. So that will loosen out a little bit and you can reposition. Okay. Then anything else anybody would like to tell me?
Should you do it under GA or can you do it in the labor room itself? Ideally, it should be done under anesthesia, isn't it?
Now I'll tell you what you can rightly do actually. You asked that question when it should be repositioned. Now, supposing you are conducting the delivery, Reena, and if it comes, when it comes down, you have recognized it, don't wait. Immediately push it back. Don't wait for anesthesia.
Yeah.
But supposing it has come and is referred to you and the case is a long drawn one and it is lying there, then the ring becomes very tight, Amma. So then you can't do it.
You can't manipulate.
So I'm just telling all of you all, in fact, I must tell you all this happened, this particular case happened several years back. And in fact, this landed with a maternal death. In fact, this landed with a maternal death. And when she came to me, I was actually operating. I was doing a hysterectomy in the theater, my theater day. And then they came and told me that the patient was brought dead. Okay. So I asked them, bleeding on bleeding illa, madam, everything they said. So when by the time I went, our sisters over there, they will quickly wrap up the patient and, dress up the patient and all that once death is a thing. So when I went, I was wondering, why did this patient die? And then actually I removed the dressing, everything. And when I put my hand into the vagina, I was so shocked. It was actually a partial inversion. If it was recognized and corrected, we could have actually saved the patient. Okay, now I just slightly modulated it so that the take-home message to everybody, and everything has been told to me by my panelists. This is inversion. The first is a dimpling. We never recognize it. We recognize it probably in the second stage. You saw the B in which it has come down. Sometimes we say only the 3 stages. It comes as far as, it comes through the internal laws and into the vagina. Okay. And sometimes it is whole thing is inside out. Then it is very easy. That Reena thought, Meera thought of it itself, I give my full marks to Meera. Because without seeing anything, she's thought of an inversion. Okay. So you'll have to start IV fluids. And as this one, Bindu rightly said, stop the oxytocin. As Jita said, give tocolytics. And immediate repositioning is the best thing. Immediate repositioning before she goes into shock. നമ്മൾ കണ്ടു നമ്മൾ തിരിച്ചു വെക്കുക ഉടനെ തന്നെ. പക്ഷെ ഇതിൽ ഒരു കാര്യം കൂടി ഉണ്ട്, അത് തിരിച്ചു വെച്ച് കഴിഞ്ഞിട്ട് നമ്മൾ കൈ എടുക്കുമ്പോഴില്ലേ നമ്മുടെ കൂടെ അത് അങ്ങനെ തന്നെ തിരിച്ചും വരും. Then again you push it back, again it will go, and then again you take your hands out, again it will come out. So keep your hand there for a long, maybe 1 hour, 2 hours, you may have to keep it there till the uterus. Then as Bindu said, restart the oxytocin. So when you restart, then it normally contracts over your hand. Okay. So this is exactly how you will repositioning it. You heard Reena tell you that. See, you see the second picture. That's exactly how we put our hand. Keep the fundus of the uterus on the palm of your hand and keep your fingers between the ring and the uterus. Now just see the orders which I have written below. What comes down first goes in last. So നമ്മൾ ഇങ്ങനെ push ചെയ്ത് ആ ring ആണ് നമ്മൾ stretch ചെയ്തുകൊണ്ടിരിക്കുക. അവസാനാണ് fundus പോവുക. Okay. Start tocolytics, stop the oxytocin. Cup your hand as shown with the fundus against the palm and the fingers between the ring and the uterus. Push it well into the abdomen above. See, when you're pushing it, no? നമ്മൾ പുഷ് ചെയ്യാൻ പറഞ്ഞില്ലേ, അത് കൈ ഉള്ളി വരിക്കും, ഇത് വരിക്കും കൈ കയറിക്കോട്ടെ. You saw my hand on the screen. Let your whole hand go inside so that your uterus goes above the level of the umbilicus. Unless you have seen an inversion, you will never know the intensity of what I'm telling you. Because when you push it that high, what happens? The ligaments get stretched. The ring gets stretched. So push it well into the abdomen above the umbilicus. This stretches the ligaments and widens the ring. The fundus reaches last. Then keep your hand like a fist till you saw that last picture. This actually I got from the neck, this picture. Keep your hand like a fist till the uterus contracts. Now you will add oxytocin. Before we had stopped, now you will add the oxytocin because you wanted to contract on your hand. Now, as they rightly said, you can keep it. Meera was trying to tell you, you can keep it. You can keep the nozzle. See, the woman is put in deep Trendelenburg. If your labor room cot can go in deep, no, our cot cannot go deep Trendelenburg. But if it can go, let it go. A sterile douche can, or you can put your, Euro bag or whatever. A little warm fluid will be fine. Keep it at about 3 meters height. The nozzle is kept in the posterior fornix, okay? And seal it with your hand so that the fluid doesn't come out. So what happens, the fluid will distend the vagina and it will get automatically. I have never done it, but I've heard that people in Calicut are great specialists in this. So I'm sure many of you who are sitting there and who have passed out from Calicut, etc., will know more about it. I have never done, I've always done a manual repositioning. Even a chronic inversion, I have repositioned manually. Okay. So keep the douche can at about 2 or 3 meters above. Alternative method is what Meera said. You can keep a, it's silicone cup. Don't use a metallic cup. The silastic cup is better. Placing in the cup and then just let fluid go. Just connect to the other end and then just cup the thing. The cup will hold it and hold the fluid inside the vagina. Okay. So I added some masala. Okay. Cervix was not,
have to go in for surgery.
Not reposition, a tight constriction ring. What next? What will you do? Anybody can answer?
You either vaginally or abdominally. There are several techniques, spinally, halting, and
no. But vaginally, have you done it? I have never done.
No, I haven't done. I've only even both abdominally also haven't seen.
Oh, I've done it abdominally. I've done it abdominally. I've done
you pick it up.
Yeah. Halting. Huntington's is the one which you put
cut the ring.
Yeah. The laparotomy, the Huntington's method. And then I just simply added masala. We failed and we did the haltings. But I'll just tell you, this is how it is done. It is just a quick normal inversion, no? You can hold the round ligaments with 2 alleys or 2 Babcocks. And then you just keep on keep on. It might come back. You'd be lucky. I've even done this last thing. This is not my picture, it is from the net. You saw that constriction ring. You'll have to do, the Dobbins is the anterior constriction. We do the Haltens method, and you just make a cut in the ring. And when you cut it, after that, you let an assistant from below push the fundus in. Per abdomen and vaginal procedure. So per abdomen, you cut the ring. A ring, a constriction ring and arrow over there. You just make a nick with your scalpel, and as you keep on cutting, you'll realize that's a large cut, Makla. It's not just a small cut. It becomes a large cut. It will be from the fundus till the cervix, actually. Till there, the cut will actually think. And then you'll be able to push it in, and then you close like a posterior classical. You understand what I mean? Put 2 or
Yes.
3 layers and then you just, I have not done it. I've done it on a chronic inversion, the Haltons. And I've done it and I have sutured it thing. So that is my last slide. I must say a big thank you to my wonderful panelists. I want all of you all who are listening to this know that I have not shown them these slides at all. What they answered is because of their brilliance. I have shown them only that first slide of the case, nothing more. And whatever they have answered, I think you've done a wonderful job. If there is no one to clap for you, I'm there to clap for you. Okay, it was a wonderful job. And as I wind up this panel, let me thank all of you all the spectators and everybody. And last but not the least, Dr. Ambujam, we dedicate this panel to you. Thank you so much.
Thank you, ma'am. Thank
Thank you,
you.
madam.
Thank you, ma'am.
Thank you, ma'am.
Thank you, madam, for that excellent panel. It was so interesting. We were sitting with actually ഇങ്ങനെ ഒരു സിനിമ കാണുന്ന മാതിരി ദൃശ്യം 2 കാണുന്ന പോലെയാണ് എല്ലാവരും ഇരുന്നത്. Okay, so Pramila, so I think we have reached the end of the session. Pramila, would you like to say the vote of thanks, please?
Thank you. First of all, let me start from Ambuja Madam and Venu sir. Thank you for being here and felicitating the meeting. Thank you, Ambuja Madam, for all the help you have done. And we are looking forward after your presidentship, once you become free, we are looking forward more help from you. And I think Nishi Madam is there. Thank you, Nishi Madam, for saying the welcome address. And the person whom I should thank the most is Serena Madam. I actually contacted her only 1 week back. Actually, I was a little embarrassed to contact her just before 1 week saying, Madam, could you do this panel? I was expecting what she will tell me, but she, as usual, with grace, she accepted it. And I can't say enough to congratulate you, Madam. It was an excellent panel. And all who have heard it, it was really good. And we were enjoying each and every minute of this panel. And to select the panelist also, Madam gave me the full freedom to select the panelist. And we wanted to have some new faces into it. And the first person that came into my mind was Meera Madam. Actually, she is my teacher. And for a long time, we have not heard anything from Madam. So I wanted her to be on the stage. And Bindu Madam and Reena Madam are always associated with talks. And we wanted their inputs also. They are into the maternal mortality and the near miss studies. And we also wanted new faces to come up. And Dr. Jida from Amala, I know she's a very soft-spoken person. Unless she is asked to, she won't say anything. But she's a person with a great potential. And Dr. Shyamala, actually, initially, I contacted Madam. Kalyani Kuti Madam, sorry. Lakshmi Kuti, sorry. Lakshmi Kuti Madam first. Then it was Lakshmi Kuti Madam who suggested your name. I just asked her, will she be talking nicely? Lakshmi Kuti Madam said 100% she is a great person for your panel. And you have proven that you are a great panelist. And we are expecting more from you. And thank you to all the panelists and Serena Madam. It was really a great pleasure to view this panel. Okay. And if I was not the secretary, actually sometimes due to some other reasons, I might not have heard this panel. I am really thankful that I am secretary here and I had to be here. And otherwise I might have even missed it. And thank you. It was a great panel. And thank you, Rashmi Madam, for putting together the scientific program. And last but not the least, thank you, Janitri and Mr. Arun, for all your support. And thank you, all the Toxians. We will again meet on Saturday evening, 5 o'clock. I promise from next month onwards, we will keep it little more lighter because all the K4 committees are going to end. That's why we wanted to finish all the committee meetings. That's why it has become so packed this week. From next month onwards, we will give you some breathing space. Don't worry.
Okay,
Thank you. So we will, good night. We will wind up the session. Thank you.
Bye.
Bye.
Super.
Pramila, bye.
Bye.